This conference will now be recorded.
Welcome, everybody. We are going to be talking about documentation in this lecture. This is going to cover Chapter 4. This is a very important aspect of our job. Because basically, if we didn't write it down after that call is concluded, then that never happened. Documentation is probably the least favorite thing that many EMTs, many paramedics will talk about, but it is such a vital thing within the EMS system because we improve based on it with quality assurance and quality improvement because our medical directors, our training officers, our program coordinators will be able to go back and kind of relive the call that you were on using this and then use that in order to improve the organization and improve you as an EMS provider as well. We also utilize it for data elements. You know, how many times have we pushed Narcan in the last year for certain organizations? And then it also helps protect us in the court of law. So if we get taken to court for some call that we were on, we can go ahead and access this report. And then lastly, we utilize reporting in order to protect our jobs because we are community servants. So in order to get paid or get new fire trucks or get new SCBAs, get new medical gear, we need to show to the community, hey, this is how many calls that we went on last year. Hey, city council, this is our response times. So in order to gain all that stuff, we are going to utilize the pre-hospital care report. So it can be one of two things. It could be an electronic pre-hospital care report, which probably 90% of EMS and fire departments utilize, or it could also be a paper copy report. Not very commonly used anymore. And even if you are using a paper copy, you are going to have to go in and complete an electronic pre-hospital care report too, because all of our reporting has got to be submitted to the national EMS data system and then whatever state that you're operating in. So for us operating in the state of Minnesota, once we complete our electronic pre-hospital care report, that gets sent to the state for their data elements, and then it also gets sent to the national level for their data elements. This is what a paper copy is going to look like. So a lot of organizations, they use both. I'm going to use this paper copy while I'm on scene. If I'm a captain or in charge of that call, I can start jotting down some different notes. And then once I get back to the station, I then can use that paper copy in order to dive deeper into my electronic care report. This is also used for when we're transferring care. So for us, we're EMTs, or at this current level, EMRs for some of you. So I'm jotting down these notes. There's a carbon copy behind this paper. Then I can go ahead and tear it off and then give it to whoever my ambulance service is that's going to be taking over patient care from there. This is an example of what an electronic version would look like. Now there's a bunch of different programs out there that different organizations utilize. This one's called emscharts.com. I know Hermantown, we use ImageTrend. Gold Cross Ambulance, they use Zoll RescueNet software. Superior Fire Department, we just transferred over to ESO reporting. It's whatever your organization needs or wants to pay for, basically. And I will go through the entire ImageTrend report. So we have different functions, and I briefly touched on that during my introduction. First, it's a patient care record. So not only when we upload these reports does it go to the state and then also the national level, but they do get shared with the hospitals as well. And so that ER physician, that ICU physician, they can go back and see all of the care that's been rendered to this individual. So this is very important, you know, because when we're given verbal handoff reports, sometimes we miss different elements, but make sure that it's documented properly, or else bad things can happen, like medication errors. Again, I touched on that legal document. So diving deeper into this, and we didn't touch too much on it when we were talking about legal and medical aspects, but if you get taken to court, it's not like you're going to get taken to court next week after a call. Oftentimes this happens 1 year, 2 years, even 3 years down the line. So in order for you to remember what occurred on this call, the only real thing that you have to reflect upon is your memory, and then also your pre-hospital care report. So the more detailed you are, the easier it's going to be for you to look at this document and then reflect back on that call, because you're going to have to answer a bunch of different questions in pertinence to that call. Same thing, it's a legal document. So everything that you entered on that report basically is stating that, yes, I did this as a competent EMT. If you didn't record it or report it, then the legal system is going to say that you did not actually perform this skill. So if you get a cardiac arrest patient and you are filling out your pre-hospital care report and you didn't specify in there that you performed chest compressions, you get taken to court and they say why you didn't perform CPR. Well, it's not listed in your report. Next, administrative purposes. Again, your training officer is going to use this, your medical director is going to use this in order to better train your individuals. And then also this is a good thing to keep track of how much equipment is being utilized as well. Education and research, talked about quality assurance, we talked about quality improvement. Now with research, we are behind the 8 ball as EMS providers. Where we get all of our trauma research from is from the military. Where we get most of our medical research as far as the pre-hospital setting goes is from doing proper documentation with these reports. So this is how we improve EMS as a whole, is by documenting properly and then being able to pull up that data in order to do that research. So we have different elements within that pre-hospital care report. We have data elements, we have run data, we have patient information, then also information gathered during that call. And then we have a narrative section where we can actually dive and paint a story or paint a picture behind that. So diving deeper into some legal issues, confidentiality, we didn't touch too much on HIPAA when we were talking about legal issues, but we have to abide by HIPAA. So HIPAA is the Health Insurance Portability Act. So all of our information in relation to patients has got to be protected. We can't share that information with anybody. So all of these reports have to be protected and they have to be stored properly in a secured place. We can't share any information at all. This is the #1 leading cause of firefighters, paramedics, EMTs losing their jobs right now, is because everybody's social media happy. So they'll go out on a call, then of course they have to post it on Facebook, and then they release some HIPAA information and they end up losing their jobs. Patient refusals, I touched a little bit on that. Make sure that you are documenting the crap out of any type of patient refusals and making sure that that individual actually signs their name. Next, falsification. Again, if you didn't do something, or if you didn't write something down, then you didn't do it. Now, on the reverse side of that, some individuals will falsify their records to make it look like they are doing or did more for that patient. You know, maybe they forgot to put a patient on oxygen and they just go ahead and document that. That's a falsification, and again, that will end up losing your job. So this is an example of a refusal form. So there's going to be a bunch of different disclaimer information in there. That individual has to go ahead and sign that document stating that they understand the ramifications upon refusing. And so make sure that this refusal form will then go with your PCR. For our paper copies, when we correct an error, this is how we do it. So you can see it is one cross out of the error because you still have to see what's underneath. You can't just scribble it out. And then you can go ahead and put error, the date, and then your initials. Now for electronic versions, I will show you guys how to correct those errors. Now there are some special considerations as far as proper documentation goes. First, when we're looking at a mass casualty incident where we have a ton of patients, then sometimes all you have to do is fill out one report because you're not going to get all the information needed in order to gain a full report. Other things, exposure to any type of infectious disease. So this is going to be a separate report, and we'll talk a little bit more about this when we're talking about the wellness of the EMT. Injury to ourself and other coworker. Again, we'll talk about this in the wellness of the EMT. But these reports we have to do in great detail and hand it off to our supervisor immediately because we have to get checked if we are exposed to an infectious disease. And then also we want to protect ourselves as far as insurance goes. And then this can be a separate report or within your narrative, any type of hazard or unsafe scene that you might have occurred. And so you want to document that properly of why that care might have been hindered at all. And then referrals to social services, mandatory reporting, both of these correlating to our younger patients or kids, maybe our geriatric patients who can't care for themselves anymore. But we want to get additional help for these people so we can report to social services and then also law enforcement and hopefully get the care or help that these individuals need. So this is an example of a bloodborne exposure incident. And now I'm going to guide you through a electronic PCR. So if we go back to our USB drive that I gave everybody, and we're going to go to our clinical paperwork, report writing instructions. So this is going to be our username. This is our password. This is the site that we are going to go ahead and use. So this is the State of Wisconsin Image Trend site. Lucky for us, they went ahead and put a generic username and password together for individuals training. So our username is going to be EMS PROV. Testing 1 is the password. It is a capital T. It's going to ask you to abide by release of information. You're going to hit yes, and then it's going to bring you to the main menu. So from here, we're going to click on incidents, and then it's going to be Wards Elite form updated under the create new EMS. And now it's going to start to generate our blank report so that we can go ahead and enter our information. For those of you who can hear, I have 3 basset hounds and they're super annoying sometimes. So this is the general layout that we're going to see with any type of pre-hospital care report in the electronic version. First, it's going to ask us who our agency name is. So when you log in, when you're a part of an organization, that organization will be in that drop-down menu. Because this is a testing site, it's just showing image trend testing. Then you have to document your unit number, so whatever rig that you went on, or in a lot of cases, you're going to be able to put personal vehicle if you responded to that scene in your own truck or your own car. So we'll say that our unit number is 123. Our call sign is going to be whatever we're designated as. So if I'm working on Hermantown Fire and I'm on engine 1, my unit call sign would be Hermantown Engine 1. My primary role is going to be whatever my primary role is for my organization. So we'll continue to use Hermantown Fire as an example. So we are a non-transport unit, and we're going to classify ourselves as rescue because we have EMTs on board. Now the other ones, if you actually transport, you could be ground transport, it could be air transport, or if you're operating within like a Suburban or a tactical vehicle. We're going to select non-transport rescue. Level of care for this unit, it is level of care for your organization. So let's say that myself and Sam were both paramedics on Hermantown Fire, and we're responding to a call together. We're not going to put ALS paramedic just because our certifications are there, but we're going to put BLS EMT because that's the level of care that we're providing on Hermantown Fire. First arriving unit, self-explanatory. We'll say that we were the first ones there and we were an engine company. So this is where you're actually going to enter in the certification level. So we're going to put Fred Flintstone, he was there. He's operating as an EMT basic. And his primary role was doing a primary patient caregiver. I'm going to go ahead and add him in. Then we had Darth Vader. He was an EMT, and he was also performing patient care, but he was another patient caregiver. So we can see once I entered in all the pertinent information that I needed to, my validation score got higher, and then also the section on the left side got to be blue. Apologize, I wasn't sharing my mouse. So then report number, your incident number is going to be generated by your dispatch. EMS response number, some organizations use that, some people don't, but then your patient number. So if you have a mass casualty incident, you can generate reports from the same report, but you're going to use different patient numbers for different patients. And then your EMD performed is your emergency medical dispatch performed. St. Louis County, Douglas County, all of the dispatchers are trained at that EMD level, but sometimes we don't know whether they were actually given instructions or not. So we'll say no, because we don't know if they actually received that information. So complaint reported by dispatch, we'll say that we were paged out for a 52-year-old female patient with abdominal pain. So I'm going to select abdominal pain. And then with my dispatch priority, we're kind of using the triage system. So are they critical? Are they emergent? Are they lower acuity? Almost everybody is emergent at this point. Now, if they're walking out to the ambulance, then I could go ahead and put lower acuity. Where I was dispatched from, so I'm going to go ahead and put dispatch from my station or Hammerstead. Type of service is going to be almost always 911 response for our scope of practice. Now, if we start working for Gold Cross or a different system, then we might use some of these different drop-down menus. We were the first arriving unit on scene. How we responded with lights and sirens. So we're going to go ahead and put emergent. We only had one patient there. Response mode, we went with lights and sirens. Now I entered all that information in. I could see my validation score went up to 70, and now my response info is blue. Now I'm going to go down to my incident info. So patient disposition is how that patient was rendered care. So they were treated and transferred care to another EMS unit, and that was Gold Cross Ambulance. Address is going to be 123 Main Street, or whatever location that you are at. Now, when we are doing these mock patient write-ups, or when you're doing them for your clinical experience, do not put any pertinent patient information in there. So make up date of birth, make up names, make up addresses. This was at a single residence. See that there's a bunch of different places that you can actually choose from. So choose the most pertinent destination where that patient was found. And we're going to say this was in Postville Green, Wisconsin. Zone numbers are oftentimes associated with your different areas within your district. So for example, Superior Fire Department, we have 3 stations, 3 engines. So when we're operating out of headquarters, that's going to be our zone 1. Times are pretty self-explanatory. Put them in when you were notified, and you can receive this from that dispatch information when you were en route. So we're going to go when we arrived on scene, when we arrived at our patient, and then when we transferred care to that other agency, and then back in service. So you can see that some things were highlighted in red, some were not. So with that, there are certain data elements that need to be processed by both your federal and your state levels. Other information can be chosen by your medical director and by your training officer, your program director. Next one down is mileage. Mileage, not a concern unless you are a transport unit. So if you are actually transporting, that's where you actually have to enter in your miles, because that gets associated with your billing. Next one down is going to be your any type of delays. So your dispatch delays, your response delays, if your scene delays. Now, if you leave these blank, it's implied that you did not have any delays. Now, if you had a response delay, maybe there was a hazmat incident, you were waiting for that scene to become safe, then make sure that you document that properly. Next, it's going to be our patient information. Again, when we are doing this, make sure that you make up names. So we're going to say John Doe, or no, it was 52-year-old female. So Jane Doe. She's a female. We can see that there were repeat patients with the same name. So oftentimes you can actually go in there and pull previous information. So it makes your life a little bit easier actually doing this. She was white. Date of birth was 1/1/1945. Her home address, it's going to be the same as where we went. Social Security number, most of the time we don't have to worry about that if we are a non-transport service. Now, if we are a transport service, we need that Social Security number in there for that billing purpose as well. So next, getting down to patient past medical history, we'll say that she's got gout. Last oral intake was lunch today. Current medications, I'll say aspirin. Now, if she doesn't have any allergies, then you're going to click this button, no known drug allergy. This is going to give you a drop-down menu of a couple of different things. This button here is going to give you an easier access to all those different medications, whatever you feel more comfortable with. Medical history obtained from, so if she was able to give us information, then I'm going to hit patient. If family member was there and they gave us the most information, then I would put family, or I could enter both. Now we'll say that she didn't have any type of advanced directive, so we'll go ahead and put none. My past medical history is now in the blue, so I'm good to go on that. Next, going down to barriers to care, I'm going to put none. Patient acuity level, I'm going to put emergent. Patient complaints, this is where you can actually enter in your information that you want. So abdominal pain, those are primary. She's been complaining about that for 2 days. Hit OK, and then it's going to save that patient complaint. A lot of patients will actually have multiple complaints, so you can add in those multiple complaints. Next is going to be your assessment. So I assessed that patient, or Fred Flintstone did, upon patient arrival. She was normal. For mental status, neurological assessment, normal. Head was normal, and then I can just continue going down in all the different findings that I had for that relation. Now, I'm not going to go through every single drop-down menu. This is going to be something that we're going to work on Thursday as far as the skills lab. So chief complaint, it was abdominal pain. We're going to assume that it was associated with the gastrointestinal tract. Primary symptom was pain. Date last was 2 days ago. Other associated symptoms, maybe she was complaining of some nausea and vomiting as well. Indications for an invasive airway. Now, if we inserted a King or an iGel or an advanced airway, we can enter that, but we didn't do that, so we're going to leave that blank. Alcohol and drugs, that is oftentimes a mandatory reporting system, and I didn't see any unseen, so I'm going to put none reported. She was about 140 pounds. Okay, so now my blue assessment is done. So now I'm on to my impression. So I said she's got abdominal pain. And sometimes it's difficult to find the exact thing that you actually want to look at. So I'm just going to put pain chronic. Other associated symptoms, she was saying nausea without vomiting. Pain scale, I asked her pain level. She said an 8 out of 10. She was open to open up her eyes. She was oriented. She obeyed commands. And that automatically gave me a GCS score of 15. GCS score is going to be our Glasgow Coma scale, which we'll dive into a little bit later on when we talk about patient assessments. Provider actions. This is where you're going to enter in everything that you did, as well as putting that in your narrative. So if I checked the blood sugar, patient arrival, procedure, check the blood sugar. Fred Flintstone did that. He was an EMT, wasn't vascular access. I did it once, it was successful. It didn't change the patient at all, and there was no complication behind that procedure. Hit OK, and then that's going to go ahead and save my procedure. So then I'm on to vitals. Vitals were taken right when I got there. Darth Vader took them. Was not obtained prior to EMS arrival. She was alert. So her heart rate was at 78. Quality, it was a normal pulse. Respiratory rate was 18. Normal. Blood pressure was 142. 96. Checked it on her left arm. Manually oscillated. Say her blood sugar was 98 when we checked that. O2 sets for 95. Go ahead and hit OK, and now we can see our vitals went to the blue. So we're at 99%. The last thing that we got to do is go ahead and enter in our narrative. So on this program, you can do a auto generate of the narrative, and it's going to give you your subjective, objective assessment and plan way in order to document. Now the textbook's going to give you a couple of different ways as far as how you can document, but this is the general way that I like to write my reports. So I auto-generated, but that's not going to give me all the information that I actually need in my report. So I'm going to go ahead and fill out an additional narrative. So I always start off with where I was dispatched and how I was dispatched. So I'm saying I'm Hermantown Fire Department. We were dispatched in the city of Hermantown for a, how old was she? 74-year-old female. So that is where I was dispatched and why I was dispatched. From there, I'm going to enter my scene arrival, what I found, how I found the patient, what position she was in, and then kind of the airway, breathing, circulation stuff. Then I'll go ahead and put whether she was alert or not, breathing adequately, and then pulse. From there, I will put what the patient's chief complaint was. So from there, I also want to document everything that I did. So and then I can dive deeper into exactly what I found with that detailed assessment of that patient's abdomen. I'm not going to bother putting down exact vital signs because that is already actually located in my auto-generated narrative. And then I always conclude my narrative writing with how that patient was dispatched or the disposition. So patient was transferred care to Gold Cross ambulance. Hermantown Fire returned back in service and available. So now we can see my validation is at 100%. My report is done. I'll dive deeper into doing a more thorough narrative on Thursday as well. But that is the nuts and bolts of documentation. So that concludes chapter 4. And again, we will dive deeper into this when we start doing some hands-on activities. Thanks, guys.